Did you know that a tiny bacterium, often living silently right there in your stomach, could be linked to conditions far beyond just, digestive issues? We're talking even some cancers, persistent skin disorders, or maybe even surprising neurological challenges.
Yeah, it sounds almost like science fiction, doesn't it?
Yeah,
But it's very real.
absolutely. Here on the Deep Dive, our mission is always to distill complex research into insights that are clear, surprising, and hopefully truly actionable. Okay, let's unpack this.
Right. So today, our deep dive takes us into the really intricate world of Helicobacter pylori. You'll often just hear it called H. pylori.
Okay.
And while, yeah, a lot of people associate it primarily with stomach ulcers, its story is, well, it's far more complex and widespread than that.
Yeah.
Comprehensive reviews, meta-analyses like the ones published in Frontiers in Cellular and Infection Microbiology, they really highlight this.
So it's not just ulcers then.
Not at all. We're not just looking at what H. pylori does in the stomach. We're exploring its pervasive nature, its, frankly, surprising connections to a whole host of what we call extragastric diseases, things happening elsewhere in the body. And we'll get into the evolving landscape of diagnosis and treatment, too, especially given this growing challenge of antibiotic resistance.
And when you say surprising connections, you really mean it, right? I think you're about to hear about links that might genuinely make you pause and just say, aha.
Definitely.
We'll uncover the revolutionary discovery that completely overturned how we understood the human stomach. And then we'll dive into the complex dance of, well, how do we actually pinpoint and treat this widespread, often hidden invader?
It really is a fascinating journey, something microscopic having such a profound and, yeah, sometimes mysterious impact on our overall health.
Okay, so to really understand the silent invader, we first need to sort of peel back the layers. Let's look at its fundamental blueprint. What exactly is H. pylori, and how did we even discover something so uniquely adapted to survive where nothing else seemingly could?
Well, at its core, H. pylori is what microbiologists call a gram-negative flagellated microaerophilic bacterium.
Okay, broke that down a bit.
Right. So gram-negative just refers to how its cell wall reacts, or rather doesn't react, to a specific stain we use in the lab. It's a key identifier. Flagellated means it has these incredible whip-like tails, flagella, basically tiny propellers that let it move around purposefully.
Little motors.
Exactly. And microaerophilic, that's its kind of superpower. It actually thrives in environments with lower oxygen than normal air.
Yeah.
That makes the mucus layer lining the human stomach its perfect little niche. So you put all that together, and you get this biological survivor. It's uniquely adapted to colonize that really harsh, highly acidic environment of the stomach. And often, it sets up shop there for decades, maybe even a lifetime, without the host even knowing it's there.
And its ability to just do that, to live there, it fundamentally altered medical science, didn't it? Because before, the mid-'80s, the assumption was the stomach was sterile, too acidic for anything.
That's absolutely right. Yeah, that was a deeply ingrained medical dogma. It was dramatically reversed in 1984. Two rather audacious Australian scientists, Barry Marshall and Robin Warren, they successfully cultivated and characterized H. pylori.
Okay.
And they weren't just identifying a new microbe. They were the first to directly link this specific bacterium to chronic gastritis, that persistent inflammation of the stomach lining, and also to peptic ulcers.
That must have been huge.
Oh, it was. It was a discovery so groundbreaking, so paradigm-shifting, that it earned them the Nobel Prize in Physiology or Medicine back in 2005. Their work didn't just add a new bug to the list, it completely reshaped our approach to gastric health. We moved away from just thinking about acid suppression for ulcers to actually targeting the bacterial cause with antibiotics.
Didn't one of them drink it to prove the point?
Yes.
Yeah.
That was Marshall. He famously drank a culture of H. pylori himself, developed gastritis just as predicted, and then cured himself with antibiotics. It was a pretty dramatic testament to his conviction and just how revolutionary their findings were.
Incredible. So we've established H. pylori is this tenacious survivor, but here's the really startling part of its story, right? It's not some rare medical curiosity.
Not even close.
It's like this hidden guest living in potentially half the world's population, often completely undetected. It's just astonishingly widespread.
That's the sheer scale of it, yeah. Infection rates for H. pylori are incredibly high. They can reach as high as 80, even 90% in certain populations globally.
80 to 90%. Wow.
Oh, yeah. The highest prevalence is consistently seen in developing countries. So, for example, among adults in Africa, rates often exceed 80%. In Latin America, it's around 63.4%, and in Asia, we see rates about 54.7%.
So it really varies geographically.
Massively. And just to give you a more concrete number, recent estimates suggest something like 589 million people in mainland China alone are infected. That's a prevalence of 44.2% within that huge population.
Those numbers really paint a vivid picture of its global footprint.
They certainly do. And then in stark contrast, you look at highly industrialized Western countries, particularly in North America, and they tend to have some of the lowest prevalence rates. North America comes in around 37.1%.
Still pretty high, though, even at the lower end.
It is. And even within a country like the United States, we see significant disparities. For instance, H. pylori is known to be more prevalent in Hispanic and Native American individuals, followed by Afro-Americans, and then Caucasians.
Why the difference?
It really underscores how global prevalence is influenced by this complex interplay of socioeconomic factors, things like urbanization, sanitation infrastructure, access to clean drinking water. These can vary hugely, even within different regions or communities of the same country. Now, thinking about how H. pylori actually spreads is primarily through two main routes. Either directly person-to-person contact or indirectly from an infected person may be contaminating the environment somehow.
Okay.
The main mechanisms are pretty well established as fecal-oral and oral routes.
Right, the classic routes for many infections.
Exactly. And we have direct evidence for this. Scientists have detected H. pylori DNA in human feces, in saliva, and even in suprajugoval plaque. That's the dental plaque found above the gum line.
So it's literally in mouths and elsewhere.
Yeah. This widespread presence of its genetic material really points to how readily it can spread, especially within households or other close-knit communities. It makes it a pretty intimate invader, you could say.
So it's not just about general hygiene in a broad sense, which is maybe the first thing people think of with bacteria. It sounds like there are other, maybe more specific factors that significantly increase the risk of acquiring H. pylori. Can you elaborate on those?
Absolutely. Yeah, beyond basic hygiene, studies have definitely shown associations with specific environmental and lifestyle factors. For instance, people in high-pressure professions, maybe healthcare workers or those in densely populated living situations, they can have increased exposure.
Okay, makes sense.
The quality of water supplies is also a major factor, especially in areas lacking adequate purification. Lifestyle choices like smoking and even specific dietary habits have been implicated in higher acquisition rates.
Interesting. A diet, too.
Potentially, yes. And there's also this fascinating recent area of research suggesting that the composition of an individual's own gut microbiota, their unique community of gut bugs, might actually contribute to intrafamilial transmission.
You mean the bugs you already have might help H. pylori spread between family members?
That's the idea, yeah. It suggests the existing gut ecosystem could somehow facilitate H. pylori's spread, which adds yet another layer of complexity to understanding how it gets around.
And once you are infected, what's the likelihood your body can just clear it on its own? Or does H. pylori typically, settle in for the long haul?
Unfortunately, yeah, once it's established, H. pylori infection typically persists for life. Spontaneous clearance, where the body manages to eradicate it without any medical help, that's actually quite rare.
So it sticks around.
It really does. And this persistence, combined with other factors, contributes to surprisingly high recurrence rates, even after someone goes through treatment.
Why is it so hard to get rid of?
Well, several things make true eradication tricky. For one, if the treatment regimens, the therapeutic schemes, aren't optimally designed or followed correctly, they can just have inherently low eradication rates. Insufficient treatment times are another common issue.
Right.
But beyond that, H. pylori itself has developed some incredibly clever survival strategies. It can actually colonize the oral cavity, your mouth, which can then act as this hidden reservoir for reinfection later, potentially undoing successful stomach treatment.
Sneaky.
Very. It can also transform into these things called cocoid shapes. They're dormant, rounded forms that are much more resistant to antibiotics and harsh conditions. And perhaps most significantly, it can form biofilms.
Biofilms, like a protective shield.
Exactly. They're these adherent aggregates of microorganisms all encased within a protective matrix, like a microscopic, slimy fortress. It shields the bacteria against antibiotics and the body's own immune attacks, making eradication much, much more challenging.
Okay, so we've established that H. pylori can set up permanent residence in the stomach, and it's a remarkably resilient survivor. Now, let's zero in on the specific damage it can inflict there first, the known offenders, if you will.
Yeah.
We're diving into conditions of the upper gastrointestinal tract where the link to H. pylori is really well established.
That's right. The spectrum of gastric conditions directly tied to H. pylori infection is pretty broad and, yeah, well understood now. It's considered one of the most common causes of chronic gastritis.
Which is that persistent inflammation of the stomach lining.
Exactly. And just to give you a sense of how common, in one study looking at patients with dyspepsia, indigestion and chronic gastritis, a striking 83.8% of them were found to be infected with H. pylori.
Wow, the vast majority.
Yeah. The bacterium's unique features, like that urease enzyme we talked about that helps it neutralize stomach acid, along with its specific virulence factors, they allow it to not only survive in that harsh acidic place, but then actively trigger intense inflammatory responses in the host that directly contributes to these often debilitating gastric issues.
And ulcers too, of course.
And of course, it's a major, well-documented cause of peptic ulcer disease, those open sores that develop on the inside lining of your stomach or the upper part of your small intestine. And then we move into sort of more serious territory. Things like gastric mucosa-associated lymphoid tissue lymphoma, or MULT lymphoma for short, and ultimately gastric cancer.
Right. This raises a really important question then. Why is H. pylori considered such a powerful risk factor for gastric cancer, not just, a casual association?
It's definitely not casual. It's a direct, recognized link. This tiny bacterium can seriously mess with the DNA in your stomach lining cells, essentially setting the stage for cancer development over time.
That's scary.
It is. The International Agency for Research on Cancer, which is a leading global authority, they've classified H. pylori as a Class I carcinogen. That's the highest classification for cancer-causing agents, alongside things like asbestos and tobacco smoke.
Wow, Class I.
Yeah. And its attributable fraction, meaning the proportion of cases directly caused by H. pylori in non-cardiac gastric cancer, that's cancer of the main part of the stomach, has dramatically increased in estimates. It went from about 74.7% up to a staggering 89.0%.
So for almost 90% of those cancers, H. pylori is the direct cause.
That's what the data strongly suggests, yeah. For the vast majority of non-cardiac gastric cancers globally, H. pylori isn't just a risk factor, it's the direct identifiable cause. This translates to roughly 780,000 cases of gastric cancer globally each year that can be directly attributed to H. pylori infection.
How does it do that? The inflammation.
The chronic inflammation and the damage from things like ulcers caused by the ongoing infection lead to persistent DNA damage in those gastric mucosal cells. That paves the way for cancerous transformations. Furthermore, specific virulent strains, particularly those carrying the KAGA-positive genotype, they're significantly associated with an even more elevated risk of gastric cancer compared to strains that are KAGA-negative.
So the type of H. pylori matters again.
It really does. But there is encouraging news here. Numerous studies have clearly demonstrated that eradicating H. pylori can actually reduce the incidence of gastric cancer. And there was a randomized intervention study that found a cumulative protective effect on gastric cancer mortality, starting about 8 years after successful treatment.
So getting rid of it makes a real difference.
Absolutely. It really underscores the critical importance of early diagnosis and eradication when it's medically indicated.
Okay, but now prepare for some of those truly aha moments we mentioned, because H. pylori's influence seems to reach far, far beyond the digestive system.
Yeah, this is where it gets really fascinating.
This bacterium living in your stomach is like a master of disguise, surprisingly linked to conditions you would genuinely never expect. It's kind of astonishing, isn't it? This stomach bug doesn't just stay put. It seems to trigger systemic ripple effects, subtly influencing conditions all over your body, from blood counts to skin health. It's a true testament to the hidden interconnectedness of our biological systems.
You're absolutely right. The extragastric manifestations are remarkably diverse, and honestly, they continue to surprise researchers. Starting with hematologic conditions, so blood-related issues, we see significant links to unexplained iron deficiency anemia, or IEA.
Anemia? How?
Well, a study from Pakistan, for example, showed that 37.5% of anemic patients who also had H. pylori had IDA that couldn't be explained by other typical causes. And crucially, H. pylori treatment has been shown to improve both anemia and iron status, especially in moderate or severe cases. It seems to interfere with iron absorption somehow.
Okay. And B12?
We also observe connections to vitamin B12 deficiency. H. pylori infected patients are notably more likely to be deficient. And again, the presence of that CAGA-positive strain and higher gastric inflammatory activity are significantly correlated with this deficiency, suggesting a direct role in messing with nutrient absorption. Moving on to skin conditions, there's a strong, really intriguing link to rosacea. That's the chronic inflammatory skin disorder affecting the face. Yeah. One study found that an astounding 80.9% of rosacea patients were infected with H. pylori, and there was a direct correlation between the infection rate and the severity of their rosacea symptoms.
How on earth does a stomach bug cause facial redness?
The proposed mechanism involves H. pylori producing things like cytotoxins and nitric oxide within the stomach. These then seem to affect vasodilation, inflammation, and immune modulation systemically, somehow triggering these skin responses from a distance. It's complex.
Any other skin links?
Yes, chronic urticaria, or CU basically, persistent hives. Patients with CU are 6 times more likely to have an H. pylori infection compared to control groups. That's a big difference, 27% versus about 10%.
6 times more likely. Wow.
And eradicating the infection in these patients has shown remarkable results. It reduces accompanying GI symptoms, significantly improves the therapeutic response of their hives, sometimes within just 2 weeks, and importantly, it reduces the recurrence rate of the hives even 3 months later.
So treating the stomach helps the skin. Incredible.
It really is. The connections extend even further, reaching into the realm of neurologic diseases. Researchers have observed associations with conditions like Alzheimer's disease, Parkinson's disease, multiple sclerosis, and even Guillain-Barré syndrome.
Neurological diseases. Okay, that's definitely unexpected.
Yeah. For example, a close link between H. pylori, seropositivity, meaning evidence of exposure, and Alzheimer's disease mortality in men has been noted. In Parkinson's disease patients, a higher prevalence of H. pylori infection has been found, and some studies even suggest the infection might worsen disease severity.
Now, this is where it's probably important to apply some critical thinking, right? While these associations are observed and definitely intriguing, studies in this specific area, the neurologic links, sometimes give conflicting results, don't they?
That's a very important point, yes.
For instance, I think I read some research, maybe a study on Japanese Alzheimer's patients, that found no significant difference in H. pylori prevalence compared to healthy controls. So while the connections are fascinating and absolutely warrant more investigation, the conclusions aren't always definitive across the board here. It reminds us that correlation doesn't always equal causation, and the biology is likely really complex.
Exactly. You've hit the nail on the head. And similar complexities in, ongoing research are evident with hepatobiliary system diseases. That's a group including conditions like cholangiocarcinoma, non-alcoholic fatty liver disease, hepatic carcinoma, cirrhosis, and autoimmune liver diseases.
So liver and bile duct issues too.
Yeah. Long-term H. pylori infection, particularly with those more virulent CAGA-positive strains, has been linked to the development and progression of cholangiocarcinoma, which is a rare but very aggressive cancer of the bile ducts. H. pylori seems to promote liver inflammation, fibrosis, and necrosis, all processes that can drive carcinogenesis. There's even a noted link between H. pylori-induced injury, especially when there's also iron deficiency, and altered bile acid metabolism. This altered metabolism can further promote gastric carcinogenesis, suggesting this really complex systemic interplay that affects liver health too.
So it sounds like while the associations are definitely there, the precise mechanisms are still very much being unraveled. There's some active debate and ongoing discovery in clarifying these specific biological pathways.
That's precisely the current state of the science. Absolutely.
Right.
And finally, there are even theoretical links to respiratory conditions like asthma.
Asthma. Okay, how could that possibly be linked?
Well, this hypothesis involves broader concepts like the gut-lung axis, which suggests that what happens in your gut can indeed influence your lung health. It also touches upon ideas like the disappearing microbiota hypothesis or the hygiene hypothesis. These propose that a lack of early exposure to certain microbes might alter immune development, potentially contributing to conditions like asthma later on.
Right, the idea that being too clean might backfire immunologically.
Something like that. H. pylori is specifically hypothesized to influence crucial immune balances, affecting the delicate ratio of different T-cell subsets, like Th1, Th2, and Th17 tregs. These T-cells play pivotal roles in immune regulation and inflammatory responses throughout the body, providing a potential pathway for H. pylori's distant influence, even on the lungs. And just to really underscore this widespread non-gastric impact of H. pylori, let's take a deeper dive into its fascinating and increasingly recognized association with colorectal cancer, or CRC.
Okay, colorectal cancer, even though H. pylori lives in the stomach.
Exactly. It's crucial to remember H. pylori exclusively colonizes the stomach. It doesn't actually live in your colon. Yet its infection is increasingly and strongly associated with various extragastric diseases, and CRC is a particularly notable and frankly concerning example.
How strong is that link?
Epidemiological studies consistently report an almost twofold increased risk for H. pylori-infected individuals to develop CRC, so nearly double the risk.
Wow.
And while, direct colonization of the colon is unlikely, any H. pylori genetic sequences found down there are probably just from non-viable bacteria passing through indirect causal and functional links have recently been revealed. This means H. pylori's presence and activity up in the stomach can still profoundly influence what happens much further down the digestive tract. Let's get into the specific epidemiological associations with CRC. There was a significant meta-analysis in 2022 which meticulously combined data from 17 different observational studies. It concluded that H. pylori infection is an independent risk factor for overall colorectal polyps.
Polyps being the precursors often.
Often, yes. They found an odds ratio, or OR, of 1.67. This means individuals infected with H. pylori are approximately 67% more likely to develop these polyps in general.
Okay.
Breaking it down further, the infection was associated with adenomatous polyps. Those are considered precancerous lesions, with an OR of 1.71. For advanced adenomatous polyps, which have a higher potential to become malignant, the risk was even more pronounced, with an OR of 2.06.
So over double the risk for the more dangerous polyps.
Exactly. Hyperplastic polyps, generally less concerning, also showed an association, an OR of 1.54. Interestingly, though, no association was found with sessile serrated polyps, which just highlights the specificity of this link. It's not all polyps equally.
That's a fascinating nuance about the virulence factors again. Can you elaborate on how these specific genetic variations within H. pylori seem to significantly amplify its impact, even from a distance, on something like colorectal cancer? It really seems it's not just the presence of the bacterium, but which version of it you have.
You've hit on a critical point there. It's truly about the bacterium's specific weapons or tools. For instance, VAC-A seropositivity, meaning having antibodies to that VAC-A toxin, slightly increased the odds of CRC with an OR of 1.11. But interestingly, this effect was notably stronger in African Americans, where the OR jumped to 1.45.
Why the difference there?
It suggests that maybe genetic background or environmental cofactors might play a role in how strongly VAC-A influences CRC risk in different populations. Another virulence factor, HCPC seropositivity, also showed increased odds, an OR of 1.66.
And Kadega again.
In CAGA, yes. Studies have clearly demonstrated that those CAGA-positive H. pylori strains are associated with increased inflammation and also a higher expression of K67. That's a marker for cell proliferation, specifically in colonic tumor tissues.
So even though CAGA acts mainly in the stomach, its effects are seen down in the colon tumors.
That's what the evidence strongly suggests. These specific virulence factors, even though they originate and act predominantly in the stomach, seem capable of initiating or at least influencing inflammatory and carcinogenic processes throughout the entire gut. They're sending signals, essentially, that contribute to disease progression far from their primary home base.
So what does this all mean for the delicate balance of our intestinal immunity and that vast, complex world of our gut microbiome? It's a truly intricate crosstalk, isn't it? How does a stomach bacterium manage to affect something so seemingly distant?
It absolutely is an intricate interplay. The presence of H. pylori in the stomach doesn't just stay localized in its effects. It actually elicits a systemic pro-inflammatory response that kind of ripples throughout the body. This involves the recruitment of various immune cells into the gastric mucosa itself. But at the same time, the bacterium's specific virulence factors are incredibly clever at evading our innate immune mechanisms and actively manipulating T-cell responses. This allows it to maintain that chronic infection for years, sometimes decades. This systemic inflammatory response is really a key piece of the puzzle linking H. pylori to diseases beyond the stomach, like CRC. When we talk about immune system modulation specifically, H. pylori actively promotes a pro-inflammatory immune response not only in the stomach, but also in the small and large intestinal epithelia further down.
How does that show up?
Well, it's characterized by the infiltration of certain immune cells called CD3 plus T cells and the secretion of inflammatory signals like interferon gamma, IFNG. And importantly, it activates this pro-carcinogenic signaling pathway called PSDA3. That pathway is involved in cell growth and survival, and when it's overactive, it can significantly contribute to cancer.
So it's flipping switches that encourage cell growth.
In a way, yes. Furthermore, H. pylori can diminish the number of regulatory T cells, or TREGs. These TREGs are crucial for dampening immune responses and maintaining immune tolerance, keeping things in balance.
So it reduces the calm down signals?
Right. And concurrently, it induces pathogenic T cells, specifically FOXP3 plus IL-17 plus T cells, which are known to promote inflammation. So you get this double whammy. Fewer regulatory cells and more pro-inflammatory cells. These combined shifts in the T cell landscape contribute significantly to colon carcinogenesis. They might even dampen the effectiveness of our anti-tumor CD8 plus T cells, which are our body's natural cancer-fighting cells.
It's like it's disarming our defenses.
There's even emerging evidence that H. pylori might induce regulatory dendritic cells that further impair the functions of these critical CD8 plus T cells. So yes, potentially disarming some key immune defenses against cancer. The intestinal mucosal barrier is another absolutely crucial element in this whole equation. It's our vital defense line, a physical and immunological barrier separating the trillions of microorganisms in our gut from our internal body environment, maintaining homeostasis.
The gut lining.
Exactly. Disruption of this barrier, leading to what's often called leaky gut, is known to predispose individuals to conditions like colitis and colorectal cancer.
Okay.
The current hypothesis is that H. pylori-induced inflammation, even though it originates way up in the stomach, may increase gut barrier leakage further down. This allows an influx of various antigens and immune-stimulating molecules from the gut lumen into the underlying tissues, which in turn contributes to intestinal carcinogenesis.
And KAGA is involved here too.
And once again, yes, KAGA, that predominant and highly aggressive virulence factor, seems to be especially involved in this complex process of barrier disruption. Finally, let's delve into the gut microbiota alterations, or what we call dysbiosis. We know the gut microbiota plays a driving role in CRC development. What's truly fascinating is that H. pylori infection doesn't just impact the gastric microbiota where it primarily lives. It also leads to significant and systemic changes in bacterial colonization patterns, even in the distal large intestine, far from its primary site.
So even though it's not physically living in the colon, its presence way up in the stomach can send ripples throughout the entire digestive ecosystem, subtly shifting the balance of the gut microbiome way down below. That's incredible.
Exactly. That's what the research is showing. Studies show H. pylori influences the overall gastric microbiota composition, often leading to lower alpha diversity in the stomach, meaning fewer different types of bacterial species, which is generally seen as a sign of a less robust or less healthy microbial community.
Okay, less diverse in the stomach, but what about the colon?
The effects extend far beyond. In the colon, H. pylori infection has been associated with an expansion of mucus-degrading species like Akkermansia spp and Ruminococcus spp.
Mucus degrading. Is that bad?
Well, these bacteria, while sometimes present in healthy guts, can become problematic if they overgrow because they actively break down the protective mucus layer, which is our gut's first line of defense. Alongside this increase in mucus degraders, there's often a significant loss of mucus-producing goblet cells, the cells responsible for making that protective mucus in the first place.
So the shield gets thinner and weaker.
Precisely. This directly points towards impaired intestinal barrier function and a disruption of overall gut homeostasis, both of which are known to actively promote inflammation and tumor development. And if we look even closer, analysis of human fecal microbiomes in H. pylori-positive patients has revealed other significant shifts. For instance, there's often an enrichment of what we consider pro-carcinogenic taxa, like Prevotalaceae and Haemophilus.
More bad guys.
Potentially, yes. And conversely, there's a concerning decrease in beneficial short-chain fatty acid, SCFA producers. Bacteria like Pseudophavonophoracter, Allostypes, and Helicobacter.
Why are SCFAs important?
Oh, SCFAs are absolutely vital for gut health. They provide energy to colon cells, they help maintain the gut barrier integrity, and they possess powerful anti-inflammatory properties. So their reduction is a significant concern for overall gut health and inflammation control.
Got it.
Furthermore, increased abundances of other CRC-associated taxa, like Succina vibrio, Corybacteriaceae, and Peptostreptococci have been observed. It paints a picture of a microbial environment that's more conducive to cancer development. And interestingly, even in children with H. pylori-induced gastritis, shifts in their fecal microbiota have been identified. They tend to shift towards more gram-negative, LPS-producing bacteria like beta-proteobacteria, lactobacillus, and streptococcus.
Oh, what's the concern there?
These types of bacteria might contribute to low-grade intestinal inflammation even early in life, and could potentially play a role in the later development of inflammatory bowel disease, IBD, and even colorectal cancer. It suggests the effects might start young.
Any other shifts noted?
Interestingly, some studies have also found higher levels of lactobacillus species, like L. salivarius and L. acidophilus, in H. pylori positive individuals. This might be some kind of compensatory mechanism by the host, or perhaps it's due to H. pylori's influence on gastric acid secretion, which can alter the overall pH and conditions throughout the digestive tract, favoring certain bacterial growths over others.
So a really complex ripple effect on the whole gut community.
Exactly. So to kind of tie this all together, the H. pylori-induced dysbiosis of the intestinal microbiota, combined with those related pro-inflammatory immune responses we talked about, and the crucial intestinal epithelial barrier dysfunction. These are the likely very interconnected explanations for the increased H. pylori-associated CRC risk. It's a powerful systemic effect originating from what seems like just a localized infection way up in the stomach.
It's really clear that H. pylori is more than just, a simple stomach bug. It's a cunning and pretty sophisticated operator. So how does this bacterium actually wreak havoc once it's set up shop? What are its primary weapons and mechanisms of disease that allow it to persist and cause such widespread issues?
Right. At its core, H. pylori's pathogenic mechanism really relies on two key interconnected abilities. First, its remarkable capacity to effectively colonize the human stomach despite those incredibly harsh conditions. And second, its expression of specific virulence factors. These are the tools that directly cause damage or subtly manipulate host processes to its own advantage. Let's first look at its brilliant colonization factors. One of the most critical is definitely urese. This enzyme is absolutely essential for H. pylori's survival in the highly acidic stomach environment.
How does urese work again?
It works by converting ingested urea, which is naturally present in the stomach, into carbon dioxide and ammonia. This ammonia then creates this localized protective alkaline cloud right around the bacterium, effectively neutralizing the harsh stomach acid and allowing H. pylori to survive where other bacteria simply cannot. And beyond just survival, urese also has pro-inflammatory properties itself. It actively promotes cellular processes that contribute to the chronic infection. For instance, it can push endothelial cells towards reactive oxygen species, ROS-dependent differentiation programs, further fueling that inflammatory cascade. Another crucial colonization factor is its flagella. Remember those whip-like tails?
Yeah, the little motors.
Exactly. Think of them like tiny, sophisticated propellers. They provide motility, allowing H. pylori to cleverly maneuver and actually burrow deep into that thick, viscous mucus layer lining the stomach. They even use different motility modes, like a thruster mode and a traction mode, to navigate effectively.
So they can really swim through the mucus.
They can. This helps them get deep into the mucus to find their preferred low-oxygen hideout near the epithelial cells, evading the stomach's main defenses in the lumen. But beyond just movement, flagella also play a crucial role in promoting that biofilm formation we mentioned earlier.
Right, the protective slime shields.
Exactly. Those biofilms protect the bacteria from antibiotics and harsh conditions, making eradication harder. And H. pylori has been shown to actually modify its phenotype, its metabolism, even reshape its flagella when it grows inside a biofilm, adapting cleverly to its fortress-like environment. Now, onto the key virulence factors, the bacteria's real weapons. What's truly fascinating here is just how sophisticated this bacterium is in manipulating our own host cells. They're not just passive invaders, they're actively hijacking our cellular machinery.
So they're not just sitting there, they're actively hijacking our cellular machinery and kind of flipping switches to their advantage.
Precisely, yeah. The most extensively studied and perhaps the most insidious of these is KEGA, or cytotoxin-associated antigen A. This is a particularly potent weapon.
How does KEGA work?
KEGA isn't just released by the bacterium. It's actively injected directly into human gastric epithelial cells. It uses a specialized needle-like structure called a type 5e secretion system, or T4SS.
Injected.
Yeah. Once it's inside the cell, KEGA acts like a molecular saboteur. It interacts with and dysregulates multiple host signaling proteins. For example, it can cause aberrant activation of a protein called SHP2, which then messes up the RAS-ARK signaling pathway that's a critical pathway involved in normal cell growth and differentiation.
So it disrupts normal cell control.
Exactly. This manipulation not only stimulates chronic inflammation, but also directly contributes to carcinogenesis by regulating processes like apoptosis or programmed cell death, and even inducing genomic instability by causing DNA double-strand breaks. Because of these powerful direct cancer-promoting effects, KEGA is actually designated as an oncoprotein. Another major virulence factor is VACA, or vacuolating cytotoxin A. This is a diffusible, pore-forming exotoxin. What it does is induce the formation of these large vacuoles, basically fluid-filled sacs, within our eukaryotic cells.
Vacuoles, what do they do?
Well, think of vacae like a saboteur of your cell's internal recycling plant. Normally, cells have this brilliant system called autophagy to clean up old or damaged parts and keep things running smoothly. But vacae disrupts this system. It promotes defective autophagosomes.
So the cell's trash doesn't get taken out properly?
Essentially, yes. When that cellular trash isn't properly cleared, it builds up, causing internal stress, damaging the cell's DNA, and significantly increasing the risk of that cell eventually turning cancerous.
Nasty stuff.
It is. Furthermore, vaca has this remarkable ability to selectively affect certain immune cells, specifically myeloid cells, within the gastric mucosa. It influences the immune response by upregulating certain immune molecules like IL-10 and PGF-beta. This, in turn, hampers the activation of effector T cells, the ones crucial for clearing infections, while simultaneously fostering the differentiation of those regulatory T cells we mentioned. So it essentially dampens the host's effective immune response against the bacterium, helping it maintain its chronic foothold. And what's perhaps even more powerful is the synergy of these virulence factors. Different H. pylori strains often carry these factors in combination. For instance, the VACO S1 strains commonly carry CAGA, whereas CAGA-negative strains typically carry the less virulent VACO S2-2 genotype.
So the bad wars often come together.
Exactly. And research has definitively shown that VACA can actually act as a co-stimulator for CAGA phosphorylation. That enhances CAGA's activity and accumulation inside the gastric epithelial cells during infection. This creates a powerful, synergistic pathogenic impact that significantly increases the risk of developing severe gastric diseases.
So understanding that synergy is key for future treatments.
Absolutely. Future research really aims to find ways to specifically block or eliminate these combined effects that could significantly improve H. pylori eradication strategies and, ultimately, reduce the risk of associated diseases.
Okay, given H. pylori's widespread impact, ranging from chronic gastritis all the way to cancer and then all those surprising extragastric conditions, getting an accurate diagnosis seems absolutely crucial for effective treatment. So how do we actually find this elusive invader inside the body?
That's right. Yeah, getting the diagnosis right is step one. The diagnostic landscape for H. pylori is broadly divided into two main categories. Invasive methods, which typically require an endoscopy to get tissue samples directly from the stomach, and non-invasive methods, which are, just like the name suggests, less intrusive and often more convenient for the patient.
Okay, invasive and non-invasive.
Exactly. And each approach has its own distinct advantages and, of course, limitations. The choice often depends on the specific clinical situation, the patient's symptoms, and what information the doctor needs. Let's begin with the non-invasive examinations, because they offer significant convenience. The urea breath test, or UBT, is a remarkably effective method.
How does that one work again?
It cleverly leverages H. pylori's unique ability to produce that urease enzyme. Patients drink a solution containing urea labeled with a safe isotope, either carbon-13 or carbon-14. If H. pylori is present in the stomach, its urease will break down this labeled urea into ammonia and labeled carbon dioxide. That labeled CO2 is then absorbed into the bloodstream, travels to the lungs, and is exhaled. We measure the labeled CO2 in the breath, and if it's elevated, it indicates an active infection.
Pretty clever. Is it accurate?
It's renowned for its high diagnostic accuracy and its simplicity. It's considered an excellent tool, particularly for checking if treatment worked, assessing short-term eradication success after a course of therapy to confirm the bacteria are actually gone.
So the urea breath test sounds remarkably clever and useful. What are some of the practical challenges or situations where its accuracy might be compromised? Could it give a misleading result sometimes?
That's a key point. Yeah, it's not foolproof. Its accuracy can indeed be impacted if patients have recently taken certain medications, specifically proton pump inhibitors, PPIs, or H2 receptor antagonists, H2RAs.
The acid-reducing drugs.
Exactly. Those medications reduce stomach acid, but they can also suppress H. pylori's urease activity temporarily, even if the bacteria are still there. This can lead to false negative results. The test says no infection when there actually is one.
Okay, so timing matters with medications. Any other issues?
There's also a risk of false negative results in patients who have what's called corpus predominant gastritis, where the infection might be more concentrated in the main body of the stomach rather than the antrum, where the test is most sensitive. This could lead to an insufficient bacterial load being detected. And just a minor note, while the 14C UBT version is quick and inexpensive, it does involve a very small, though generally considered safe, amount of radiation exposure. That's something to consider, especially maybe in pediatric patients or during pregnancy, where the 13C version, which uses a non-radioactive isotope, is preferred. Another widely used non-invasive option is the stool antigen test, or SAT. This test works by detecting H. pylori antigen-specific bacterial proteins directly in fecal samples.
Testing stool samples.
Right. It also boasts high sensitivity and specificity, and it's applicable to individuals of all ages, though tests using monoclonal antibodies are generally considered more effective for children. There are two main types of SATs. EIA-based tests, which are well-suited for large-scale testing in labs, but maybe sometimes have slightly diminished precision or specificity, and ICA-based tests, which are more like rapid point-of-care tests. They're convenient, don't require specialized equipment, are especially suitable for economically disadvantaged regions, and often noted for better precision and specificity right there in the clinic.
So it sounds like a very practical and effective option for detecting a current infection, but it doesn't give us the full historical picture, right? Like, did someone have it before?
That's a crucial distinction, yes. Similar to the UBT, the accuracy of SATs can be affected by certain factors, like recent gastrointestinal bleeding or recent antibiotic use, which can temporarily reduce the bacterial load or the amount of antigen shed in the stool. Upper GI bleeding in particular can significantly reduce its diagnostic sensitivity. And crucially, as you said, the SAT only detects current active H. pylori infections. If you've had H. pylori in the past and successfully cleared it, this test won't show any lingering signs. It only confirms the presence of active bacteria right now. Then there's the serological test. This is another non-invasive method, usually a blood test, that detects H. pylori-specific antibodies, typically IgG antibodies, in serum. It can sometimes also be done on saliva or urine.
Okay, antibody testing.
Its advantages are that it's generally inexpensive, non-invasive, and remarkably convenient for large-scale epidemiological research, things like surveying infection rates across big populations or just identifying past exposure in individuals.
Now, here's a really critical point for understanding test results with serology, the antibody tests. Because this test looks for antibodies, a positive result doesn't necessarily confirm an ongoing active infection, does it?
Exactly right. That's the major limitation for clinical use.
Your body can produce antibodies that persist in the blood for several weeks, or often much longer, sometimes even years after the infection has actually been cleared. So while it's excellent for knowing if someone has ever been exposed to H. pylori in their lifetime, it's generally not suitable for assessing whether a treatment has successfully eradicated the infection. The antibodies might still be hanging around long after the bacteria themselves are gone.
Absolutely correct. Now, turning to the invasive examinations, these typically begin with endoscopy. This procedure allows a physician, usually a gastroenterologist, to directly visualize the gastric pathology. They insert a thin tube with a camera down into the stomach to visually inspect the lining for signs of inflammation, ulcers, or other abnormalities.
Seeing it directly.
Yes. They use techniques like standard white light endoscopy and sometimes enhanced imaging like linked color imaging. These have pretty high diagnostic accuracy for identifying active gastritis. Linked color imaging can be particularly useful for spotting more subtle signs, maybe in patients who've had inactive gastritis in the past, and it helps guide where to take biopsies from.
But it's important to stress, right, that just looking with the endoscope shouldn't be used alone for diagnosing H. pylori. While it shows the potential damage, its accuracy and specificity for detecting the bacterium itself can vary quite a bit. So it's almost always combined with other, more specific tests using biopsy samples.
Precisely. You need confirmation. And one of the earliest methods for that, still considered a gold standard for definitive diagnosis and also for monitoring the H. pylori infection status, is histology.
Examining the tissue itself.
Exactly. This involves taking small biopsy samples during the endoscopy and then meticulously examining them under a microscope back in the pathology lab. The pathologist can directly visualize the bacteria clinging to the stomach lining and also assess the degree of inflammation and any cellular changes in the tissue. It provides a very direct and comprehensive picture. Then there's the rapid urese test, RUT. This is another common invasive method, but is performed right there during the endoscopy procedure itself. It's simple, cheap, and provides remarkably quick results, often within minutes to an hour.
How does the RUT work on a biopsy?
Similar to the UBT, it relies on H. pylori's urese enzyme. A small biopsy sample taken from the stomach lining is placed into a special test gel or liquid that contains urea and a pH indicator. If H. pylori and its urese are present in the biopsy, the enzyme breaks down the urea, producing ammonia. This ammonia raises the pH of the medium, causing the indicator to change color, usually from yellow to pink or red, indicating a positive result.
Quick and easy then.
Generally, yes. And taking biopsies from both the antrum, the lower part of the stomach, and the gastric body, the main part, simultaneously can significantly improve its performance and speed up the results by increasing the chance of capturing bacteria if they're present.
However, it must have its limitations too, similar maybe to the UBT, right? Like with medications.
It does, yes. There's a higher likelihood of false negative reactions if the bacterial density in that specific biopsy tissue happens to be low, or as you mentioned, if the patient has recently taken antibiotics or PPIs. These can temporarily suppress bacterial activity and urease production without fully eradicating the infection.
So timing matters here too.
Absolutely. Despite these potential influencing factors, though, its high specificity, meaning it rarely gives a false positive result, makes it a frequent and valuable first test choice during endoscopy to get a quick indication. And then we have culture. This involves actually trying to grow the H. pylori bacteria from a biopsy sample in a specialized laboratory environment.
Growing the bug itself, what's the advantage there?
This method offers incredibly high specificity because you're definitively identifying the living organism. And crucially, it allows for antibiotic susceptibility testing. This is invaluable because it tells the clinicians exactly which antibiotics the specific strain of H. pylori infecting that particular patient is sensitive to and which ones it's resistant to. This provides highly targeted, personalized treatment guidance.
That sounds incredibly useful, especially with resistance being a problem. But it sounds like, despite its benefits, culture isn't practical for routine, everyday clinical practice. Why is that?
Unfortunately, no, it's not routinely used. Despite its clear advantages, especially for guiding therapy, culture faces significant practical challenges. The bacteria themselves are very delicate, or fastidious, as we say in microbiology. They require specific, precise atmospheric and nutrient conditions for successful growth. This makes both sample transportation to the lab without the bacteria dying and the culturing process itself quite difficult and time-consuming.
So too tricky for everyday use.
Generally, yes. It's too labor-intensive and slow for widespread, rapid clinical application, often reserved for research or complex cases where susceptibility testing is deemed essential. Lastly, we have polymerase chain reaction, or PCR. This is a highly versatile and exquisitely sensitive molecular diagnostic tool that's becoming increasingly important. PCR can detect H. pylori DNA directly and even identify specific virulence factor genes like CAG-A or VAC-A in various types of samples, not just biopsies, but also potentially saliva, stool, and gastric juice.
Looking for the bacterial DNA itself.
Exactly. And it's generally less affected by factors like sample preservation and transportation compared to other invasive tests like culture because DNA is more stable. An advanced version, called real-time PCR, can even identify specific genetic mutations within the H. pylori DNA that are known to be associated with resistance to certain antibiotics, like macrolides, clarithromycin. This is vital information for choosing the most effective antibiotic treatment right from the outset, especially given those rising resistance rates we keep mentioning.
So PCR sounds like a really powerful tool, offering deep insight into the bacteria's genetics. But it's not without its potential pitfalls either, is it? Like any super sensitive test.
That's correct. Like any highly sensitive technique, false negative results can still occur. This might happen if the specimens are somehow contaminated during collection or processing, or if the sample happens to contain substances known as PCR blockers, which can inhibit the PCR reaction itself. However, more advanced PCR techniques, like nested PCR, can amplify DNA even from samples containing very few target molecules, significantly enhancing sensitivity and making it a more robust option even when dealing with challenging samples.
Okay, so we've successfully played detective, learning how to pinpoint this elusive invader and understand its complex mechanisms of attack. But the real battle, of course, begins with treatment. And as we'll explore now, eradicating H. pylori isn't always as straightforward as it might sound.
It's certainly not, no. H. pylori infection is notoriously difficult to eradicate effectively and reliably. There are two primary reasons for this ongoing challenge. First, the increasing problem of bacterial antibiotic resistance, which we'll definitely delve into more shortly. And second, currently, the lack of a commonly available effective preventive vaccine.
No vaccine yet.
Not one that's widely available for routine use, no. This means we have to rely heavily on complex treatment strategies, often involving multiple drugs, and these strategies are constantly evolving to try and keep up with the bacteria's evasive tactics and growing resistance. Let's first talk about the traditional empiric treatments. These are usually the first lines of defense employed, often based on general guidelines for a region rather than specific susceptibility testing for that individual patient strain. The historical mainstay for decades has been standard triple therapy.
What's in that?
This regimen usually involves a proton pump inhibitor, or PPI like omeprazole, to reduce stomach acid, combined with 2 antibiotics, clarithromycin and amoxicillin. It's typically taken for 10 to 14 days. However, its efficacy, its success rate, is unfortunately declining significantly across the globe. Why? Primarily due to rapidly increasing resistance to clarithromycin.
So it just doesn't work as well anymore?
In many areas, yes. In regions where the rate of clarithromycin resistance in the H. pylori population exceeds 15 or 20%, standard triple therapy is generally no longer considered an appropriate first-line empiric therapy because the chances of treatment failure are simply too high.
But context matters here too, doesn't it?
Yeah.
It's not necessarily a universal rule that applies exactly the same everywhere, highlighting the importance of using local or regional resistance data.
Exactly right. Context is key. For instance, in certain areas where clarithromycin resistance is demonstrably still low, some studies mention rural regions of eastern Uganda. For example, standard triple therapy might still be prescribed as a first-line treatment and can still be quite effective there.
Are there newer versions of triple therapy?
Yes, researchers are actively exploring promising alternatives to overcome the resistance challenge. One candidate gaining attention is vonoprazan triple therapy. Vonoprazan is a novel potassium-competitive acid blocker, or PCAB, which provides more potent and consistent acid suppression than traditional PPIs. This regimen, using vonoprazan instead of the PPI with the 2 antibiotics, has shown impressively high eradication rates in studies, often exceeding 90%.
Over 90% sounds great.
It does, though more global studies are needed to confirm its widespread efficacy and applicability across different populations. Another option explored is rifampicin triple therapy. One double-blind experiment in the USA found an 83.8% eradication rate, suggesting potential for first-line empirical treatment. However, it did cause some adverse events in that study, and it hasn't yet been extensively tested in Asian patient populations, so more data is needed there too. Now, in locations where there's a known high prevalence of clarithromycin resistance, specifically above that 15–20% threshold, bismuth quadruple therapy is widely advised as the preferred first-line treatment.
Bismuth, like in Pepto-Bismol.
Exactly, that kind of bismuth compound, usually bismuth subcitrate or subsalicylate. This regimen typically combines a PPI, the bismuth compound, and 2 different antibiotics, often tetracycline and metronidazole. Bismuth plays a crucial, multifaceted role here. It acts as a mucosal protective agent, coating the stomach lining, but it also directly exerts a bactericidal effect on H. pylori by inhibiting some of its key enzymes, like urease.
So it attacks the bacteria, too.
Yes, and this approach has proven quite effective in various countries where resistance rates to other antibiotics, like clarithromycin, are high, including places like India.
However, this bismuth therapy isn't without debate either, is it? It seems there's some contention among researchers regarding its widespread popularity or maybe its suitability as a universal go-to first choice.
That's true. Yeah, due to potential adverse reactions, bismuth famously causes temporary black stools or tongue discoloration, which can alarm patients, and sometimes a longer or more complex treatment cycle associated with quadruple therapy. There's indeed a contentious debate among researchers about its universal appeal.
So what's the bottom line on using it?
The decision to use bismuth quadruple therapy as an initial treatment should always be contingent on careful evaluation of local regional antibiotic susceptibility patterns, if known, to ensure the chosen antibiotics, tetracycline and metronidazole, will actually be effective against local strains. Plus, considering the accessibility and cost-effectiveness of bismuth itself in that particular region is also paramount. Beyond these mainstays, there are other regimens like concomitant, sequential, and dual therapies. These names basically describe different ways of administering combinations of medications either all together, concomitant in a specific order, sequential, or sometimes just using 2 drugs, dual.
Are any of those better?
Well, for instance, high-dose dual therapy, often involving just a PPI and high-dose amoxicillin, has been highlighted in a recent meta-analysis as potentially being the most effective treatment for H. pylori infection because it causes the fewest side effects and potentially less disruption to the gut microbiome compared to quadruple therapies. Similarly, modified dual therapy regimens are being explored and can sometimes be effective, potentially safer, and less expensive than bismuth quadruple therapy, offering valuable alternatives.
It sounds like there's a lot of promising research happening, but maybe also some inconsistencies or remaining questions in optimizing these newer approaches.
There definitely are, yeah. Discrepancies still exist regarding which specific PPI works best in these combos, the precise medication dosages needed, and the optimal duration of treatment periods for many of these newer regimens. All of these variables require further rigorous investigation through large-scale clinical trials to really optimize their use and establish clear, evidence-based guidelines.
And resistance is always a worry, especially for key drugs.
Absolutely. And given its widespread and critical usage in so many different H. pylori regimens, it's absolutely critical that we focus on strategies to prevent the emergence of resistance to amoxicillin. Losing amoxicillin effectiveness would significantly impact our foundational ability to treat these infections successfully.
Okay, so beyond the standard antibiotic regimens, researchers are exploring some truly fascinating adjunctive approaches, things used alongside antibiotics that could potentially revolutionize H. pylori treatment, maybe by boosting eradication rates, minimizing those side effects, or perhaps even helping to bypass antibiotic resistance.
Absolutely. This is a really exciting area of research. One very prominent and rapidly growing field is the strategic use of probiotics.
Good bacteria to fight bad bacteria.
Essentially, yes. These living microorganisms, particularly certain species like Lactobacillus and Limos Lactobacillus reuteri, have shown consistent success in steadily increasing H. pylori eradication rates when used alongside conventional antibiotic therapy.
How do probiotics actually help?
They seem to combat H. pylori through several clever mechanisms. They can secrete antimicrobial compounds that directly inhibit the pathogen. They can compete with H. pylori for crucial binding sites on the stomach lining, basically crowding it out. They can help improve the function of the mucosal barrier itself. And they generally seem to boost the overall eradication effect and, importantly, the tolerability of the antibiotics, often reducing common side effects like antibiotic-associated diarrhea. Another truly innovative area involves nanomaterials. Researchers are using these incredibly tiny materials engineered at the nanoscale to protect and promote the highly targeted delivery of oral drugs, specifically to the infection site in the stomach.
Nanotechnology for drug delivery, how does that work?
Well, nanomaterials offer several advantages, mainly due to their minute size. They possess higher permeability and retention, meaning they can potentially navigate biological barriers more easily and stay where they need to be for longer. They also have a remarkably high surface area relative to their volume, which allows them to potentially load more than one drug at a time, facilitating collaborative treatment and possibly helping to overcome resistance mechanisms.
Can you give an example?
Sure. For instance, amoxicillin encapsulated within lipid nanoparticles has been shown in studies to significantly enhance drug retention right at the infection site. And crucially, the nanoparticle shields the antibiotic from the harsh acidic conditions within the stomach lumen, ensuring more of the drug reaches its target intact and active. There are also novel nanomedicines being developed, like liposomes containing linolenic acid, that might even directly disrupt the bacterial outer membranes, causing leakage and delivering the drug more effectively inside the bacterial cell.
This sounds like really cutting-edge science with immense potential. But I imagine it's still relatively early days for widespread clinical use, right? Given the novel nature of these materials.
It certainly is, yeah. While incredibly promising, there's a critical and ongoing need for much more examination of their biodegradability, biocompatibility, potential toxicity, and any potential long-term health hazards. Information on these crucial safety aspects is still quite limited for many nanomedicines, so significantly more research and rigorous clinical trials are absolutely essential before they can become a routine part of standard treatment protocols. And finally, we shouldn't overlook traditional Chinese medicine, TCM. TCM has a rich history, being widely used for centuries in treating H. pylori-related gastrointestinal diseases, and modern scientific research is increasingly validating its potential efficacy.
TCM for H. pylori, how does that fit in?
Well, Chinese herbal formulae, often complex combinations of different herbs, have shown apparent advantages in treating H. pylori infection in some studies, even in cases of repeated infections where conventional therapy failed. They often boast impressive curative effects in traditional practice.
That's fascinating. Can you give us some specific examples of these TCM approaches and maybe explain how they're thought to work on a biological level according to research?
Certainly. One well-researched active TCM ingredient is berberine. It's a compound found in various plants like golden seal and barberry. Berberine has been shown in studies to effectively suppress H. pylori infection, help control mucosal inflammation in the stomach, and even promote the healing of ulcers.
Okay, berberine. Any others?
Yes, Beyond that, there are several monomeric compounds, single-active molecules derived from TCM herbs. Things like copticine, ivodiamine, and patchouli alcohol have been shown to possess both direct antimicrobial activity and powerful anti-inflammatory properties, specifically against H. pylori. The main mechanisms of action proposed for these TCM components are quite multifaceted and sophisticated. They might work by suppressing H. pylori replication and transcription, effectively stopping the bacteria from multiplying and carrying out essential functions. They might reduce the expression of that vital urease enzyme, weakening the bacteria's ability to survive in acid. Some might directly destroy the bacterial structure, physically breaking down the pathogen. Furthermore, they can downregulate the expression of key virulence factors like CAGA and VECA, neutralizing the bacteria's weapons, and even inhibit the activation of those host signaling proteins that H. pylori tries to manipulate.
So multiple modes of action.
Exactly. And specific TCM prescriptions, which are traditional formulae, like Shenling Bizusan and Huangqi Jianzhong decoction, have also demonstrated significant capabilities to treat H. pylori infections in clinical settings, often used alongside or after conventional therapy.
So it's not just necessarily an alternative. It sounds like it could be a powerful complementary approach, potentially working synergistically with conventional antibiotic therapies.
Absolutely. That's a key potential role. The integration of these TCM herbs and their active constituents with conventional experiential therapy has the potential, based on emerging evidence, to yield substantial augmentation in H. pylori eradication rates and significantly improve clinical efficacy in managing the various gastrointestinal disorders associated with the bacterium. This kind of holistic and integrated approach could hold immense advantages, both for individual patients in clinical settings and for overall global public health, offering a more robust and multifaceted arsenal against this tenacious pathogen, especially as that problem of antibiotic resistance continues to grow. Now, despite all these promising treatments and the ongoing research into adjuvants, we face this major and escalating hurdle, the resistance riddle. The rapid development of primary antibiotic resistance in H. pylori has become, frankly, almost inevitable.
Why inevitable?
Well, it's largely due to the limited selection of truly effective antibiotic options we have, combined with the extensive global usage of certain key antibiotics, like clarithromycin and metronidazole, not just for H. pylori, but for other infections too. This widespread use creates immense selective pressure, favoring the survival and spread of resistant strains.
And the consequence?
From a clinical perspective, drug resistance has a significant and alarming consequence. A dramatic reduction in the effectiveness of our standard H. pylori treatment regimens, and subsequently, an escalation in the complications that arise from persistent, untreated, or undertreated infection. When we look at this from a global perspective on resistance, the data is quite stark, really. Across most regions designated by the World Health Organization, primary resistance rates, meaning resistance in patients who have never been treated for H. pylori before, and secondary resistance rates, resistance after previous treatment, failure to clarithromycin, metronidazole, and levofloxacin, often exceed 15%.
15% is the threshold where standard therapies become unreliable.
Generally, yes, that's often considered the threshold for concern for empiric therapy. While there are a few exceptions, maybe primary clarithromycin resistance is slightly lower in the Americas and Southeast Asia, or primary levofloxacin resistance in the European region might be under that mark, broadly speaking. Resistance to our key drugs is a widespread and growing global concern that severely limits our treatment options.
How do the bacteria actually become resistant?
The primary bacterial mechanisms involved are usually things like the bacteria start producing enzymes that actually inactivate the antibiotic, breaking it down before it can work, or they alter the specific target site within the bacterial cell where the antibiotic normally binds, so the drug just can't attach effectively anymore, or sometimes they reduce the permeability of their outer membrane, basically closing the doors so the antibiotic can't even get inside the bacterial cell to do its job.
Clever defenses. Now, this brings us to a really nuanced point, one that raises important questions about long-term health and that delicate balance within our bodies. We're trying to eradicate a known harmful bacterium, H. pylori, but the main tools we have to do that, antibiotics, can also affect the rest of our vast and vital gut microbiome. This balance presents a profound challenge, not just for doctors making treatment decisions, but maybe for us as individuals thinking about our health.
That's precisely the challenge, yeah. It's at the heart of a lot of current research and debate. There's growing scientific attention, rightly so, on the significant and often detrimental effects of antibiotics on the broader gut microbiome. Antibiotics are increasingly viewed as potentially harmful, not just because they target pathogens, but due to their broad-spectrum impact. They often kill off beneficial bacteria along with the bad ones. This disruption to the intestinal microbiota has been linked in studies to various disorders, things like inflammatory bowel disease, and even potentially an increased risk of colorectal neoplasia down the line.
But we still need to treat H. pylori if it's causing problems, right?
Right.
Especially the cancer risk.
Exactly. Yet, despite these rising resistance rates and the legitimate concerns about microbiome disruption, antibiotics are currently the only established evidence-based option we have for preventing H. pylori-related malignancies like gastric cancer. This creates a really complex balancing act for clinicians and patients, weighing the immediate, often crucial benefits of eradication against the potential for long-term ecological shifts in the gut microbiome. So let's first look at the argument for eradication and its potential benefits, not just for the stomach, but possibly for the microbiome and beyond. The prevailing hypothesis is that H. pylori eradication may indeed play a crucial role in preventing colorectal cancer as well.
How would getting rid of a stomach bug prevent colon cancer?
Well, the idea is by eradicating H. pylori, you might reduce those pro-inflammatory CD3 plus T cells and dampen that pro-carcinogenic PSA3 signaling we discussed earlier, thereby reducing the systemic inflammation that reaches the colon. Eradication could also potentially increase the levels of those regulatory T cells, which are vital for dampening immune responses and helping to induce immunological homeostasis or balance, not just in the stomach, but potentially systemically, including the small intestine and colon.
And the gut barrier.
Furthermore, successful eradication might potentially allow the number of mucus-producing goblet cells to recover and help normalize the crucial intestinal epithelial barrier function, thereby reducing that leaky gut phenomenon and its associated risks further down the line. And several studies do support this more positive outlook for the microbiome following treatment. We've shown that for many individuals, antibiotic treatment seems to induce only short-term intestinal dysbiosis, a temporary disturbance, that finally recovers to a healthy composition with high microbial diversity.
So it bounces back.
In many cases, yes. For instance, some beneficial bacterial taxa like Blautia, Lachnoclostridium, and Bifidobacterium have actually been observed to increase following eradication in some studies, while potentially detrimental ones like allostipase decrease. The overall microbial composition seems to approach that of healthy controls over time. Other studies have found minimal adverse changes in fecal microbial diversity and composition in the longer term, even up to a one-year follow-up, suggesting a good degree of resilience in the gut ecosystem for many people.
Any other benefits noted?
Some research has even indicated potential improvements in metabolic parameters, things like insulin resistance and LDL cholesterol levels after H. pylori eradication, hinting at broader systemic benefits beyond just the gut.
Okay, that sounds really promising then, suggesting resilience in our gut ecosystem for many. But there's a counter-argument too, isn't there? This provocative idea that maybe some H. pylori-induced changes might be more permanent, almost like hitting a point of no return for the microbiome in some individuals.
Exactly. This is the argument against eradication, or perhaps more accurately, the argument highlighting the potential for long-term harms and this concept of a point of no return, implying some changes might become imprinted and persistent. Some human studies have indeed observed long-lasting and potentially harmful effects on the microbiome following antibiotic treatment for H. pylori.
Like what kind of effects?
For example, long-term decreased relative abundances of certain important bacterial groups like actinobacteria in the fecal microbiome have been identified in some cohorts, and some individuals showed a disrupted gut microbiome profile that remained significantly altered for up to 4 years post-treatment in one study. This indicates persistent consequences that go well beyond just a temporary recovery phase for some people.
Does it affect everyone the same way?
That's a key point. No, it doesn't seem to. These long-lasting changes appear to depend highly on factors like an individual's race, their genetic makeup, and also the specific antibiotic eradication regimens used. This really suggests a personalized response to treatment and its impact on the microbiome.
So let's really dig into that point of no return concept for a second. Is there potentially a point where the changes induced by chronic H. pylori infection, changes in our intestinal immune response and our microbiome, get sort of imprinted almost permanently, and they might remain even after the infection itself is completely eradicated? It's a profound and perhaps slightly unsettling thought. Could the damage in some sense already be done in certain individuals, preventing a full recovery of that intricate immune and microbial landscape, even if the inciting bacterium itself is gone?
That is precisely the core of this complex and really evolving debate, and it's a question that scientists are urgently trying to answer right now.
Yeah.
The long-term effects of antibiotic eradication therapy on the gut microbiome and overall health, especially concerning risks like CRC, are still controversially discussed, precisely because of these conflicting findings in the literature.
So more research is needed.
Definitely. More rigorous, prospective, long-term studies, particularly in diverse Western populations where maybe initial microbiome states differ, are urgently needed to confirm these findings, to really understand the underlying mechanisms driving persistence versus recovery, and to investigate the true long-term impact on CRC risk after eradication.
What's the takeaway for now, then?
It truly emphasizes the necessity for careful evaluation of the risks and benefits of antibiotic treatment in each individual case. Clinicians need to weigh the clear benefits of eradicating H. pylori, especially regarding ulcer and cancer prevention, against the potential risks of microbiome disruption and the possibility, however uncertain, of these imprinted immune and microbiome signatures that might persist beyond the immediate eradication of the pathogen. And all this needs to be considered alongside those increasing antibiotic resistance rates globally. It's a complex clinical decision. Lastly, just as a brief aside, it's worth mentioning that while H. pylori is by far the most common and extensively studied Helicobacter species infecting humans, other non-H. pylori Helicobacter species, often abbreviated NHPH, do exist and can also sometimes cause human disease, usually gastritis.
Other helicobacters, where do they come from?
These are often transmitted zoonotically, meaning from animals to humans. Common sources include dogs, cats, and pigs. They're sometimes categorized based on their appearance under the microscope. For instance, H. suis from pigs is often called H. hammonea type 1, while others like H. felis from cats might be type 2.
Are they easy to diagnose and treat?
Diagnosing these can actually be quite challenging because they are often even more difficult to culture from human stomach samples than H. pylori. So diagnosis frequently relies on more specialized methods like careful microscopy of biopsies or specific PCR tests designed to detect these other species. Their typical treatment usually includes a combination of amoxicillin and a PPI, similar to some H. pylori regimens, but often requires a longer duration of therapy.
So what does this all really mean, then? We've embarked on this pretty deep dive into Helicobacter pylori, uncovering its frankly pervasive global presence, its direct and well-known impact on gastric health like ulcers and cancer, but also its surprising, really complex connections to this wide array of extragastric conditions, most notably perhaps colorectal cancer.
Yeah.
We've explored the fascinating mechanisms behind its pathogenicity, how it cleverly survives and manipulates our cells, and we've dissected the dynamic landscape of how we diagnose and treat it, all while grappling with that escalating challenge of antibiotic resistance and its delicate, complex dance with our own gut microbiome.
Yeah, to synthesize it all, H. pylori is truly a remarkable and incredibly tenacious pathogen. Its influence extends far, far beyond what was once understood just a few decades ago. Its ability to subtly shift our internal biological landscape, particularly our immune system, and the vast, intricate world of our gut microbiota makes it an absolutely critical area of ongoing research.
And the implications.
The insights from all these studies really underscore that effective management isn't just about simply eradicating the bug. It's becoming increasingly about understanding the broader physiological context of the host, the specific bacterium they harbor, and their intricate interplay over the long term.
So, for you, our listener, being well-informed about H. pylori means recognizing its potential impact, not just for your digestive health, important as that is, but potentially for your overall systemic well-being. It really highlights the profound interconnectedness of our body's systems and also the continuous, evolving nature of medical understanding. If you're experiencing maybe unexplained symptoms that seem to align with some of these extragastric connections we've discussed, knowing about H. pylori might just be an important piece of the puzzle to discuss with your healthcare provider. And thinking ahead, this is maybe the final provocative thought for today. Given the increasing challenge of antibiotic resistance and the complex, sometimes persistent changes H. pylori can induce in our body's systems, especially our gut microbiome, how might future prevention and treatment strategies need to evolve beyond just relying solely on conventional antibiotics? Could personalized medicine, maybe considering an individual's unique microbiome profile, their genetic predispositions, even their specific H. pylori strain type, become the norm for tackling such a dynamic and widespread pathogen? And perhaps, what role might our everyday diet and lifestyle choices play in shaping our resilience not just to H. pylori, but to such microbial invaders in general?
Precisely. That's exactly where the field is heading. The future of managing H. pylori and all its associated risks might truly lie in understanding these intricate host-microbe interactions even more deeply. We need to move towards interventions that are not just about eradication at all costs, but perhaps more about restoring overall physiological balance and resilience within the individual's unique biological context. This continuous learning process just reminds us there's always more to explore, always more insights to uncover in the deep dive of medical science.
Thank you so much for joining us on this deep dive today. We hope you're leaving perhaps a little more informed and maybe a lot more curious about the hidden world within and its impact on our health.